Hello, I'm Dr. Mohammed Bayasi, Assistant Professor of Surgery at the MedStar Georgetown University Hospital in Washington, D.C. I will be presenting this lecture on non-infectious colidites. I have no disclosures. There are a number of non-infectious colidites that a colorectal surgeon will come across during their career. During this presentation, I will discuss 6 of these non-infectious colidites. This includes Divergent Colitis, Neutropenic Enterocolitis, Disinfectant Colitis, Corrosive Colitis, NSAIDs and salicylate-induced colitis, and finally, toxic epidermal necrolysis. By the end of this lecture, the listener should be able to differentiate between infectious and non-infectious colitis, recognize condition and risk factors for non-infectious colitis, distinguish between the various forms of non-infectious colitis, and discuss the medical and surgical treatment options for non-infectious colitis. I will begin this talk by discussing divergent colitis. This non-infectious colitis is believed to be due to deficiency of nutrients, particularly butyrate and other short-chain fatty acids. This theory is supported by the fact that daily instillation of short-chain fatty acids results in improved endoscopic appearance of the diverted segments. Patients with divergent colitis are often asymptomatic. However, when symptoms do occur, rectal bleeding is often the most notable symptoms. Patients may also present with tenesmus, mucus discharge, and abdominal pain. Endoscopic findings associated with symptomatic divergent colitis include mucus plugs, contact irritation, erythema, and ulcerations. In an asymptomatic patient, endoscopic findings may include tissue pallor and friability. These findings can be seen in the following images. This image is from a patient who had a long-standing ileostomy and rectal stump for chronic Crohn's colitis. This image demonstrates the tissue pallor, the friability associated with divergent colitis. This image is from the same patient, and it demonstrates the linear ulcerations without bleeding that can be seen in divergent colitis. The linear ulcerations can be seen in the 2 o'clock, 6 o'clock, and 10 o'clock positions. There is also diffuse erythema and friability seen in this image. This image demonstrates that the tissues affected by divergent colitis are prone to bleeding with ulceration. If you were to take biopsies of the diverted segment, it would demonstrate acute and chronic inflammation with or without crypt architectural abnormalities. The pathologic findings that is pathognomonic for divergent colitis is lymphoid follicular hyperplasia. Patients with asymptomatic divergent colitis typically do not require treatment. For those patients with symptomatic divergent colitis, treatment includes twice daily irrigation with short-chain fatty acids for up to 6 weeks. The typical dose for short-chain fatty acids enemas is 60 mL. If symptoms improve, then these enemas may be given less frequently. Other treatments that have been used include 5-aminosalicylic acid enemas or 5-ASA enemas, steroids enemas. However, these should only be used when the short-chain fatty acids enemas are not well tolerated. Divergent colitis resolves after intestinal continuity is re-established. However, for patients who will be diverted for more than 1 year, it is recommended that periodic endoscopic examination of the diverted segments be performed to evaluate for neoplasia. Next, I will discuss neutropenic enterocolitis, or NEC. Neutropenic enterocolitis is a potentially fatal disease that was originally discovered in patients with neutropenia secondary to chemotherapy. However, it has also been seen in patients with absolute neutrophil counts less than 500 cells per ml, as noted in many patients with HIV. Patients with neutropenic enterocolitis commonly present with abdominal pain, abdominal distension, fever, diarrhea, with or without blood, nausea, and vomiting. The most accurate method for diagnosing neutropenic enterocolitis is CT scan or CAT scan, which demonstrates thickened and inflamed terminal ileum and cecum. Though this disease has a predilection for the terminal ileum and cecum, any other segment may be affected. Though endoscopy is generally contraindicated, if performed, it will demonstrate a diffusely friable and hemorrhagic mucosa. Though adult NEC tends to affect the terminal ileum and cecum, neonatal NEC presents more diffusely, as will be seen in the next 3 slides. This is an anterior-posterior plane film of a neonate with NEC. There is pneumatosis of the small bowel in the right upper quadrant. This is a lateral film of the same patient demonstrating pneumatosis and air in portal venous system. This is a CT scan demonstrating the diffuse portal venous gas and bowel distension seen in a neonate with NEC. Treating patients with neutropenic enterocolitis remains difficult. The mainstays of treatment are bowel rest, IV fluid, and broad-spectrum antibiotics with parenteral nutrition. Patients often improve as their neutropenia resolves. However, some patients develop perforations or peritonitis. For these patients, surgical intervention is required. The necrotic segment is resected and a stoma is created. Despite these treatment options, clinical outcomes are unpredictable in this population. Next, we will turn our attention to disinfectant and corrosive colitis, which are 2 entities that share similar etiologies, endoscopic and pathologic findings. Despite rinsing the scopes thoroughly before use, some of the disinfecting solutions may remain, which can lead to colonic damage when the scope comes into contact with the mucosa. When this happens, it leads to irritation and an appearance of the mucosa that has been referred to as pseudolipomatosis. Formalin injury may occur in 2 ways. 1, formalin is used as a treatment for patients with bleeding of the rectal mucosa secondary to radiation therapy. 2, biopsy instruments may come into contact with formalin while placing specimen in formalin fixing containers. These instruments then come in contact with the mucosa, causing damage. Formalin injury to tissue can be avoided by meticulous washing of biopsy forceps when they have come into contact with formalin. This is especially true for endoscopic baskets for tissue recovery after polypectomy, since these materials can retain a high concentration of the chemical if it comes into contact with formalin and is then reintroduced into the scope. Patients who develop disinfectant or corrosive colitis typically present 24 to 48 hours after endoscopy. The presenting symptoms can range from mild pain to considerable tenderness, with fever and bloody diarrhea. It is important to rule out colonic perforation as the cause of the patient's symptoms. This can often be done with the use of an X-ray. On endoscopy, there will be slightly raised whitish plaques that may appear similar to pseudomembranous colitis. However, the plaques will appear in areas that appeared normal on introduction of the scope, but become abnormal on withdrawal of the scope. Pathologic findings for disinfectant and corrosive colitis show empty spaces within the lamina propria. No treatment is required for patients. However, prevention of this is important and can be done through thorough rinsing and forced air drying of the endoscopes. It is well known that NSAIDs and salicylates cause ulcerations in the gastroduodenal mucosa. However, these drugs may also produce colonic mucosa injury, colonic stricture formation, perforation, and hemorrhage. In addition, they are also associated with the reactivation of quiescent inflammatory bowel disease. Patients with NSAID or salicylate-induced colitis typically present with diarrhea, rectal bleeding, and abdominal pain, in addition to the history of heavy NSAID use. Patients with NSAID or salicylate-induced colitis will have endoscopic findings ranging from patchy erythema to many severe mucosal ulcerations. Treatment for this type of non-infectious colitis is discontinuing of the NSAIDs, as well as giving 5-ASA and steroid medications. Patients may require inpatient therapy, and many of these patients will have relapses. For those patients that develop chronic colitis, surgery may be indicated. Lastly, I will discuss toxic epidermal necrolysis, or TEN. Toxic epidermal necrolysis is the most severe disease on the spectrum of mucocutaneous exfoliative diseases, including Stevens-Johnson syndrome. To be classified as TEN, at least 30% of the patient's total body surface area must be involved, including at least 2 mucous membranes. The most commonly affected sites are the oropharynx, conjunctiva, genitalia, anus, and GI tract. Patients who develop TEN often have a recent history of phenytoin or sulfonamide use, acting as the trigger. Following this, patients present as a prodrome of fever and malaise. Eventually, they begin to develop bloody diarrhea. Following this, patients will develop an erythematous confluent eruption that rapidly evolves into exfoliation of the skin, resulting in large areas of necrotic dermis, as seen in the following image. This image shows a patient with toxic epidermal necrolysis prior to undergoing surgery for an acute abdomen. In addition to the skin findings associated with TEN, the mucosal sloughing that occurs can lead to melena, intestinal perforation, and segmental ischemia, as can be seen in the next image. In this image, you can see patchy intestinal necrosis in the small bowels during an exploratory laparotomy of a patient with TEN. Patients with TEN will have diffuse ulceration throughout the GI tract, and on endoscopy, this appearance is similar to that seen with severe ulcerative or pseudomembranous colitis. However, biopsies will demonstrate extensive necrosis and lymphocytic infiltration without crypt abscesses or neutrophils. Toxic epidermal necrolysis is a life-threatening disease with numerous complications, including sepsis, gastrointestinal hemorrhage, leukopenia, fluid and electrolyte imbalances, and renal insufficiency. These complications make treating these exceptionally ill patients very difficult. These patients require admission to an intensive care unit for fluid resuscitation, enteral feedings, and peptic ulcer prophylaxis. In addition, many of these patients will require surgery to resect the necrotic bowel. In summary, the non-infectious colidites that we have discussed in this module are summarized side by side in this table provided here. I'll take a few moments here to allow you to review it on your own. I'd like to thank the MedStar colorectal surgery program, as well as few individuals who contributed content for this presentation, whose names are listed here. I'd like to thank you for your attention.